whole thing is yes. Of course, the answer is yes, because the trial showed exactly that. Even if you are very stable on a ACE inhibitor or an ARB, you should be
You
shifted to
should
RD.
shift.
So there's no question about that. Again, of course, we've discussed this very often, that there's nothing like a stable heart failure. The patient may say patient feels well. They often stop exercising and they say, oh, we are not breathless, because many they're not doing much work. And of course, they still have incidents of sudden death and other options, other possibilities of severe cardiac complications. So the answer is yes. Any patient who's so-called stable on ARB or AC inhibitor should be shifted to RD.
That's a tricky one, because most of us, of course, the signs and symptoms of heart failure would be the way in which the patient would present to us. But I guess apart from using the natriuretic peptides that as a blood test for screening, we should have to be more accurate in our diagnosis. We would require at least an echo. And as Professor Coates mentioned, there is a waiting list in all other centers. Fortunately, as Dr. Dalal mentioned, in India, it's pretty easy to get an echo, and at least a basic echo, to find out what you're dealing with, and that's the way forward.
I think clinical examination is still important. I think after all, the diagnosis of heart failure is a clinical diagnosis. The heart failure diagnosis is not really a echocardiographic diagnosis or a CT or a MRI diagnosis. I think examination, and Dr. Coates will agree with that. I mean, I'm sure he's diagnosed thousands of patients just clinically on basis of clinical findings that this patient has heart failure. What do you think, Dr. Coates? Do we need all this? I know echo is important. I'm not underplaying anything, but I think clinical examination will give us a vast amount of information.
I mean, look, anyone experienced, and I'm sure many of the people on this webinar would be very talented and able to make a diagnosis of HFpEF reliably clinically, because there are signs, there are definite signs there. But the trouble is that if we're recommending it to doctors who perhaps don't have that experience and training, there will be errors. So I think it's a strong recommendation to say you really do need an echo. You should have an echo. Having said that, I wouldn't wait, and I'd be confident making diagnosis, and I know many of my colleagues would be confident, but I'd still like to see an echo at some stage.
But again, as Dr. Bhagirath mentioned, we should be careful about echoes as well, because sometimes what happens, people are not experienced. You do an echo, the usual echo report comes, ejection fraction is 60%. And the patient and the doctor says, oh, this is not heart failure, thinking the ejection fraction is normal. Many of our echo centers, though we can do it in a matter of hours, do not give us all the information about strains and diastolic function, etc. So we get a very basic echo majority of times, concentrating on ejection fraction. So we need to be careful of that.
Especially those that are done in screening camps. So they focus on the ejection fraction only, because you have multiple patients and you need to do a quick echo. So the focus is on just getting the ejection fraction numbers, and a detailed echo is often not done in mass screening programs.
How often does Dr. Bhagirath and Dr. Coates, how often do you do exercise echo for picking up preserved ejection fraction? Is that something which you do commonly, Dr. Coates?
I wouldn't say commonly. I mean, I do it a lot for clinical trials. I do it for cases where there's uncertainty, and I'll do it for evaluation of the specific etiology. So yes, I do it, but it's a particular interest of our unit. I don't think it's so common across the country.
Dr. Bhagirath, in your center, exercise echo is a reasonably often done?
No, it's as Professor Coates mentioned, we do it as part of clinical trials and investigations that where specifically it is required, but not on a routine basis, not on a day-to-day basis. But again, I must emphasize what Professor Coates mentioned, that when you follow up these patients, a CPET and a 6-minute walk test are really handy to see how the patient has improved with treatment, because as you rightly pointed out, sir, many times the patient doesn't exercise enough, and you would say he's quite okay in terms of symptoms. So we need quantification, we need numbers. So I think this must be done more regularly for the patients.
Cardiologists somehow in India at least don't do 6-minute test as often as it should be. I see a lot of pulmonologists, people who are treating
Pulmonologist,
hypertension, do a lot of 6-minute walk. But somehow
Yes.
cardiologists don't get into that 6 minute for some reason in India, and I think we need to improve that.
Fortunately for us, we work as a team, so that's always there on the protocol.
I think that would be an ideal case because, you know, it's a very effective antihypertensive agent. It works in abnormal ventricular function, you know, over the wide range of ejection fractions. So that sounds a good case. The only limitation for ARNI sometimes is patients with very low blood pressure. So it's a good thing when the blood pressure is higher because there you really know you've got almost a double benefit and a double indication.
Just to mention, of course, ARNI was initially used for hypertension, and I think the cost prohibits it being from used for treatment for hypertension per se. But now we have generic ARNI. We got, I think, 10, 12 companies now making ARNI, and the cost has dramatically come down. So I think any patient with severe hypertension and some evidence, either clinical or otherwise, of heart failure, diastolic or systolic, and not necessarily very low ejection fractions, I think it'd be a good idea to use ARNI if the cost is not an issue now with it coming down, rather than an ARB or an AC inhibitor, particularly against an ARB. I think ARNI would be a better choice for a hypertensive patient for both treatment of hypertension and for that marginal benefit in these so-called mid-range or upper mid-range ejection fractions. Dr. Bhagirath, do you
Yes, totally agree with that, sir.
Agree with that, yeah?
Totally agree with that. Yeah, you have a double benefit with one drug, so I think definitely would agree to its usage in this context. Yeah, 36-hour washout. You need to stop the ACE inhibitors, wait for 36 hours, and then initiate ARNI. Whereas if you are using ARB, you can switch immediately to ARNI. This is a guideline recommendation for the switching.
Dr. Coates, do you actually religiously follow that? Is it practically important? I know we all follow that, but sometimes it confuses the patient. They don't start the second drug. So, I mean, do you think it's a big practical clinical problem using ARNI, say, the next day after stopping ACE inhibitors?
Yeah, I mean, I'm sure you get away with it. I mean, the recommendation is doing that. But yeah, I accept there is a risk. If you tell a patient you can't take for a day and a half, the risk is they won't restart. So that's why I think really the ultimate solution is to start the ARNI from the beginning. Then you get away with all those problems.
If you have a patient with heart failure with reduced ejection fraction, we have been saying this again and again, do not do sequentially. That means if your patient's on SGLT2, you should actually question why the patient was not on ARNI. I think that's important of checklist. You have a patient in the OPD, he comes from another hospital, he's on SGLT2 but not on ARNI. So really you need to know why he wasn't on ARNI. There may be a genuine reason. His creatinine may have shot up, his blood pressure may have been 90 systolic when he left the hospital, and therefore there's a genuine reason. So now you have a reason for a patient not being on ARNI. Now you have to look at it. Maybe his creatinine has come down, his potassium has come down, his blood pressure has crept up again, and that's a good time to add ARNI. Or sometimes people just forget to add ARNI or are scared of using ARNI. So there are many reasons. So I think we need to find out why. And of course, if there is no contraindication, to immediately start ARNI. Not only ARNI, but also to start the other fillers, which are the MRI and the beta blockers. So not just look at ARNI, but look at all the 4 pillars and make sure that all 4 pillars are started, even if necessary in small doses. So it's not necessary to optimize a dose of each drug and then move on to the second drug. Start small doses of all the drugs, because once the patient is on a drug, even if it's a small dose, it's much easier to increase the dose in the outpatient rather than to add a new drug. So we tend to use all 4 drugs in the patient when the patient leaves the hospital, however small the doses may be, and then see them early in the OPD within maybe next 10 to 15 days, and then quickly step up the drugs as much as possible. One is the patient comes with heart failure, you put him on diuretics, and his blood pressure is 90 systolic, he feels a little dizzy every time he stands up, his creatinine is 2.5 and his potassium is 5.8. I mean, that's a practical problem. I mean, you start ARNI at that point, patient's not on ARNI. SGLT2 easiest to start because they don't have that much effect on the blood pressure, and they produce more beneficial effect to patient is still wet. The first thing to do is to make sure that your diuretic dose is reduced down, because sometimes too much diuretics which we give early when we treat acute heart failure, that doesn't need to be carried on. Simply reducing the dose of diuretics, the blood pressure may come up, the creatinine may start falling down. At that point in time, when you feel the patient is reasonably stable enough to take the drug, you start, and we start in very small doses. I know that the guidelines don't recommend, but we start something like 25 milligrams twice a day of ARNI instead of 50 twice a day. And I think quite happy with starting 25, judging the patient's response and then stepping it up. But there will be occasional patients in whom you simply cannot give ARNI because the blood pressure keeps dropping to 80. They cannot tolerate it at all. Creatinine shoots up, potassium shoots up. I know we got potassium binders, which you can use now to control potassium, but I still feel there'll be a small subset of patients in whom ARNI is really very difficult to start even in small doses. SGLT2 are easier. Beta blockers, of course, you can always use as long as the patient is not severely bradycardic or has some bradyarrhythmia. Again, small doses of beta blockers are quite useful. So I think I agree with you. There are practical difficulties, and which is why I think vericiguat is becoming more popular in India, because it doesn't have those problems. So even if the patient's blood pressure is 80 and the creat is 2, you can still use vericiguat without running into trouble. So therefore, these are the options and practical problems.
So basically, an echo would help you to differentiate. And whenever there's pulmonary hypertension, there's always an additional workup that's required. We go ahead in our center, we go up with a protocol wherein a CT pulmonary angio is done, and we would like to know what is the real etiology for this pulmonary hypertension. So I think if you progress in terms of the workup, it's pretty clear whether you're dealing with a heart failure scenario or a pulmonary hypertension scenario. Of course, in selected cases, we would also like to do a right heart study to see where exactly we stand in this particular profile. And then, of course, the treatment would be tailored according to the context of the patient.
My views are is that you don't need any big hospital to have a heart failure clinic. I think the heart failure clinic should be in your head. Any individual can have a known heart failure clinic in terms of what is basically the importance of heart failure clinic. The importance of heart failure clinic is that you shouldn't miss a diagnosis, you should make an early diagnosis, and you should give guideline treatment. Now, that doesn't need a big hospital. We don't need MRIs for all these patients. We don't need any sophisticated investigations. You examine the patient, maybe do an NT-proBNP if patient can afford it, do an echo, which I think most people will be able to do. And all you have to do is to make sure that the patient gets correct treatment. So if you do that, I think that's sufficient even in the smallest of place. So even a small doctor in a small setup in a small village can do good treatment for heart failure if he has the knowledge and the then the ability to do it without having the physician's inertia. Then, of course, as you get upper the thing, you can go better and better. And as Dr. Coates says, Dr. Bhagirath have big heart failure clinics with heart failure nurses and continuous monitoring. All that is possible. So heart failure clinic starts from very base, one doctor, one patient, and one simple ECG and 2D echo to an extensive investigation, including heart transplant. Dr. Bhagirath.
So, yes. so I'll make a start by saying that you need a person who can identify heart failure. That's all that you require to start a heart failure clinic. It doesn't even have to be a doctor. If you're looking at a very remote place, it can be a nurse practitioner and of course a general practitioner as well. So it's like a spoke and hub. So once you have a person who can identify heart failure, then gradually the numbers will come up, and then you'll have more and more people who will man particular parts of the heart failure clinic, and then comes in the equipment and then the expansion. So it all starts off with one committed individual who can identify heart failure. The rest of it can be built around that person.
Yeah, just educate yourself and have a simple checklist of the drugs that the patient should have and other things that need to be done. All you need to do is monitor pulse, blood pressure, and weight. That's all. Very basic, simple things. You can have your own heart failure clinic. So people who are in small places, do not get worried that you need some big setups for heart failure clinics. Dr. Coates, what do you feel? You're, of course, in the biggest center for heart failure clinics. So what do you think of the small people in the small place?
Yeah, I totally agree with what you said. A heart failure clinic is that passion and that knowledge to manage heart failure well. It's identifying that this is the most serious condition this patient's likely to have, and you need to put the effort into making an accurate diagnosis and giving the right treatment. It's a frame of mind, and use whatever resources you have.